Hello and welcome to another podcast from the National Association of Primary Care. My name's Annabelle Beasley and I'm a faculty member at NAPC. Last year, my colleague Andy Mullins and I had the pleasure of spending a few days in sunny Dorset doing some socially distanced interviews on behalf of Dorset CCG. They'd asked us to find out from colleagues across the system how they thought primary care was developing and how integration across the system was going. Over the next few months, we'll be releasing those interviews as podcasts. And first up, we have Dr Will McConnell from Dorset County Hospital. Hello, Will. Can you tell us a little bit about yourself and why you think the NHS is finally ready for integrated care and population health management?
I've been a respiratory consultant in Dorset County Hospital for the last 19 years. And when, I think it was the first day I started, the first thing the manager said to me was, can you discharge more patients, please? And it didn't take very long for me to realise that I found that really difficult because I didn't know what I was discharging them to. I didn't know what the skills were in primary care. I didn't know what the capacity was in primary care. And I didn't know what systems they had for following people up and monitoring people. And so right early on, I thought to myself, I've got to get in there. I've got to get into primary care and poke my nose in a bit, which sometimes can be a bit rude when you're trying to intrude on what other people's work. But I was quite relentless over the last few years in trying to become more engaged with primary care because, I can deal with the patients that come and see me that are referred to me and, treat them well, hopefully. But there's a limited number of them and there's not a limited number of hours in my day. What I was much more interested in is trying to treat all those other people who aren't seeing me. And how can we improve their care and improve their quality of life and so on? And that's what was, that sort of became more fascinating for me in how can I make a bigger impact than just looking after the few people who actually see me. And to make it, because, most of the disease is out there in the community and doesn't come anywhere near me. So that got me interested more in it wasn't even called integrated care then, it was just sort of poking your nose into the community and trying to see what was out there. And so we tried a number of things over the years. I mean, as the politics have changed, so certain opportunities have arisen. There was something called practice-based commissioning a few years ago, because I'd built relationships with some of the GPs in Weymouth, they commissioned a sort of what would now be called a sort of semi-integrated respiratory service from us, which basically consisted of one nurse and a physiotherapist. And that was the sort of pilot of what then went on to form what we call our DARES service, Dorset Adult Integrated Respiratory Service, which started in 2013, 2014. But of course, at that time, the whole emphasis of the NHS was different. It was to do with not cooperation, not collaboration, but competition. And you were always swimming uphill. You were swimming against the tide, walking uphill, swimming against the tide. It just was hard work trying to get anything going because you weren't, you were going in the wrong direction really. Very though talking to people, everyone agreed that it was a good idea and we should do more of it. And when you did bits of it, people would be very positive about it. And then the NHS long-term plan or the 5-year forward view and then the long-term plan came along and suddenly everything was different. And it's been amazing since then. And suddenly all the things I've wanted to do, the doors have opened and I've been running trying to keep up. And it's been great.
What impact do you think the pandemic has had on integration?
So COVID actually has been a real opportunity and has actually triggered the formation of the Southwest Respiratory Network, of which I'm a lead, and the Dorset Respiratory Network, which I'm one of the clinical leads for. So it's brought people together, and that's what's been amazing about COVID. I mean, it's been really problematic in many ways, but it has got people working together much more, and clinical people, I think, have enjoyed that. And Microsoft Teams, or video conferencing, has been amazing. It has enabled us to do much more quickly. And we never knew that. We thought we had to travel all the way across England in order to make a decision about anything. Well, funnily enough, we don't. So it's been amazing, really, over the last few months.
I think that's something that's been replicated quite widely across the country. It's Microsoft Teams and Zoom have really cut down on NAPC's travel time for sure. So what do you think what's your own sort of take on the journey towards integration in Dorset?
And so we're moving ahead in Dorset with all sorts of interventions, diagnostic hubs. I've been doing community MDTs in 3 of our primary care networks, which occur monthly. I've been doing that for the last couple of years. I've been doing clinics in GP surgeries for the last couple of years in Weymouth and Portland. And we've recruited nurses within 3 of our primary care network who can deliver the work and use the population health management tools to actually change how we're managing patients. So now I look back and I think, there was I thinking, I don't know what the skills are in the community. Well, I do know what the skills are, and I actually do know what the capacity is. I do know where the problems are in the community now, where the practices that struggle a bit. I can see the data. And so after 19 years, I think we're getting there, and I'll be able to discharge a few people soon.
I love the way that you led into that story, and that your curiosity enabled you to do what that manager had asked you to do. It's just the perfect example of why integration and closer collaboration is so important. How have you seen the system change to enable more collaborative working?
Well, I guess the main changes in the system that have facilitated this there's just the change of direction from the government or from NHS England with the 5-year forward view and the long-term plan. And Dorset was a bit ahead of that with their clinical services review, which they were having to do anyway. So we suddenly found ourselves in Dorset, having been to quite a lot of meetings from the clinical services review. You suddenly found yourself talking about collaboration and talking about integration, and realising that everything links together. You can't change one thing without affecting another, so you've just got to look at the whole system. And that became quite clear whilst we were doing the clinical services review. And then the 5-year forward review came along and said, oh, that's the solution. That's what we're trying to do. So we were always a bit ahead in Dorset, which is great. And it was good, actually, the clinical services review, because it did bring lots of clinical people into one place, and we did have a lot of meetings, which meant that trust did develop. And I think developing trust was a very important part of it. And in fact, of course, actually, the clinical people in Dorset often do know each other quite well. Often you've trained together as junior doctors, and you've worked together in various hospitals. So often people do know each other over the years. And so maintaining those relationships is really quite key. I mean, the other thing that changed in Dorset is the agreement by the trusts to be on block contracts. And I think that's very powerful, because the trouble with payment by activity is it encourages competition and all those sorts of things that don't help collaboration. Whereas put somebody on a block contract and it changes the mentality of the organisation completely. And then, for example, a hospital like this is much more willing to engage with primary care to try and prevent work coming into the hospital, which is, of course, what we need to try and do. Now, there's a balance to be struck, but going on to the block contract was a key ingredient for Dorset Now, a lot of people don't like block contracts for that very same reason, really. And if you want to increase activity, it is more difficult. But of course, we don't have the resources to increase activity infinitely. What we want to do is do things differently and more imaginatively, and not just see everything as a transactional process where you just have a patient going to a place, doing something done to them, and that's your unit of currency. You need another, much more imaginative way of looking at things. And that's what, it's not something, healthcare isn't something which you can buy in that way. And that's the mistake I think we've made over the last 20 years, is moving much more to that way. And the last 3 years, certainly in Dorset, it's changed. And it frees everyone up. It frees people's imagination.
It's great to hear that the system is changing and allowing people to, free their imagination. It's fantastic. How do you think the role of the commissioner has changed during the last few years?
Because the CCGs used to be quite distant, and all they did was commission, and they were aloof from clinical people, and there was no way in. I couldn't get in, But now they're just wanting to involve clinicians, and it seems completely different. And they're helping, they're facilitating process, they're getting people together, which is what they should have been doing all the time. The Dorset CCG has been amazing, having been a rather aloof organisation that was, I think, when the I suppose it was the Lansley changes came, CCGs through necessity weren't allowed to talk to us very much, because they were the commissioners and we were the providers, and that the commissioner-provider split was a real split, and it prevented integration, really. But now the CCG has a completely different role. It brings people together. It allows you in to influence things, and you feel as a clinician much more empowered to make a difference, which then encourages you to be a bit more imaginative and have ideas, and let's do something different and be creative.
It's really great to hear how the CCG has been such an enabler in integration. What do you think are the other sort of key enablers for population health management?
I think leadership's really important. Strategy is really important. People and relationships are really important. You need all of those ingredients. And an IT system is quite important as well. And having IT systems that communicate with one another is really important. And that's actually has turned out to be the most difficult thing. Funnily enough, the people thing, the strategy thing, that's actually fairly straightforward. But the blooming IT problem is a real issue. And it's difficult, I've certainly found clinicians who are employed by different organisations quite happy to work together, quite happy to share information, stuff like that. But the IT departments all work very separately. They're not integrated. And that forms a real barrier. So if you've got a computer, if you work for this organisation, but the computer's provided by a different organisation, and you've got a problem with the computer, you don't know which IT department to talk to solve it. And it always seems to be somebody else's problem. So those sorts of issues, you need to bring the whole thing. It's not just clinicians. You need to bring everything together, IT and recruitment, things like that. We don't want to be competing for staff. We need to be working together on recruitment and workforce. So the whole thing, but I like big system stuff. I like looking at the big picture. And you need to do that because everything interlinks.
We spoke to a couple of your colleagues in the CCG who were instrumental in developing the DICE, or the Dorset Information Intelligence Service, which for people listening is a really fantastic population health management system. Your colleagues talked about the respiratory service that you wanted to set up and have now set up, and they said you knew exactly what you wanted to look at, and that you were a really insightful customer. Can you tell us a little bit more about the impact that DICE has had on your work?
I mean, what I've always needed in order to manage West Dorset, which was my sort of catchment area, was to know information about the patients. where they are, where the disease is, where the services are working, where the services are not working so well. And that information has always been somewhat elusive. You could get little islands of information, little pockets of information from various things, but it was never ever brought together in one place. And a couple of years ago, 18 months ago maybe, I went to a meeting about population health management. I'd never heard of the term population health management. And they got up this computer spreadsheet type database thing, which was what was going to be our DICE. It was a sort of, and they just, gradually started talking about this, and it just dawned on me, this is what I've needed for years. This is what you can't do it without this. You can't really manage the health needs of a population without knowing all this information. And the power of this is just amazing once you get down to it. And the most amazing, and there are so many amazing things about it. One is that it gives you a whole view of your whole population. For example, for me, it's patients with COPD. And you get a whole view of everyone in Dorset with COPD, and you can see how bad their disease is. We can see what treatment they might have had. You will be able to see what treatment they haven't had or but should have had, and all that sort of thing. You can see which practices are doing well, which practices perform less well in various metrics to do with the quality of the care. But then, amazingly, in the same screen on your computer, you can drill down to the individual patient level data. And to be able to do that is amazing, because you can then start managing things, you start changing things. And this is what I've always wanted to be able to do.
Can you give us any examples?
It's normally about getting the basics right. It's not about complicated medicine at all. This is about making sure that a person with fairly mild asthma has the right inhaler and is taking their right inhaler. Or that similarly with COPD, or that the people who've been in a hospital with their COPD are on the right treatment to try and prevent them from coming back into a hospital. And it's not complicated medicine, but what's complicated is trying to deliver that medicine to a whole population of people and making sure that they actually use the medicine properly. And that's what it allows you to do. So normally you're talking about fairly unsophisticated interventions. So there's one, we in the west of West Dorset, a few months ago, our respiratory nurse there decided to look at, they managed to drill down on the population of patients with asthma who were using too much of their reliever inhaler, their salbutamol inhaler, that were very dependent on it. And so she was then able to determine a list of people. So who are these people? And you can find on the DICE, you can see pseudo-anonymized data or related to the patient, and then you can find out who the patient is, and then go and approach the patient to find out what's going on with their treatment and review their treatment. We drilled down on this population of patients who were overusing their salbutamol inhaler, and we were able to institute pretty basic changes. Now, we haven't followed them up yet, so this was just a few months ago. So what I'm hoping is we'll revisit them in about a year's time and just see how much of their salbutamol they've used in that subsequent year. And but to be able to just do that, and you could do that in each practice. You could do it on a practice level. But you'd have to just get everyone. The fact that we can look at a whole primary care network, or actually a whole, STP area, and see where all these pockets are. And in fact, the reason why we chose that particular area is because they stood out as an area where people were overusing the salbutamol. But there's another example. There's a treatment for COPD, which involves putting valves into your airways, which enables you to deflate your lungs, which improves the symptoms of COPD. And it's not a common procedure. There aren't many people who benefit from it. And generally, there are a few people in whom it's really effective. But often clinicians forget about it as an option. And so the normal way for patients to get this treatment is to go to the GP with a cutting from the Daily Mail to say, oh, have you thought about this? They mentioned this thing about valves in your airways. And that's the usual way people act. And they say, oh, no, I haven't heard of that. Or we'll refer you to Dr. McConnell. And Dr. McConnell thinks of it and says, oh, yes, we could refer you for that. You might be quite good for that. But it's very serendipitous whether people get this sort of treatment. But what I was able to do was to look at a whole primary care network and drill down on the people who's had the clinical phenotype, had all those characteristics that would make them potentially people who would benefit from it. So they had to have their lung function had to be below a certain level. They had to have a certain degree of breathlessness. We didn't want people who had lots of exacerbations of their COPD, because that's not what we're trying to treat with the treatment. And so I was able to drill down quite to a small number of patients who could benefit from this. I then was able to look at their x-rays, because you can tell pretty much on an x-ray who's going to benefit from it. So that gives you an even smaller pool of people. And then you've got a handful of people where you could look at their System 1 record and say, well, actually this person could, they've obviously got not lots of other comorbidities that are making them ill, therefore they could benefit from this treatment. And so eventually you've got a few people and you've given them a ring and you say, we've got this treatment, would you be interested in going down that route? Well, yes, maybe I would. And then you can give a proper, thorough assessment of them. And it's the fact that we're now, therefore, being proactive. Rather than just waiting for patients to come to us complaining of a symptom, we can actually seek out the patients that we need to assess and treat, which is going to be much better for the population as a whole. Sure, we may generate a bit more work at times, but actually in the longer term, I think we'll be doing much less firefighting and much more managing a population in a proactive way. And I think people will feel more looked after. I think the psychology of I imagine people thought the NHS was doing this all the time, was sort of looking after them behind. They didn't realise that it was all a bit chaotic and was very dependent on them coming to see us. But in fact, we are starting to do that now. And we've been spotting people who need a flu jab for years. It's that sort of thing.
Sounds like the DICE has had a really positive effect on your work and that of your colleagues. Do you think that integration and the DICE have had an effect on education?
We've always been very keen on education and training and trying just to improve people's skills generally. And you can go and do a lecture on something or a podcast or whatever people do nowadays. And that's all very well, but it doesn't really change very much. And you know this. Because you give the same lecture every year and things don't actually change that much. Because really what you need to do is change the system and you need to change the mindset of people. And you don't achieve that by doing a 45-minute talk with PowerPoint. And so even though I quite like doing PowerPoint presentations and educational sessions, I realise that they're not that effective. But what I wanted to do is to get myself embedded in primary care networks and to be delivering regular teaching through MDT meetings. So you're looking after individual patients, because of course people actually respond better to cases being presented and clinical problems and intellectual exercise rather than some data or something, graphs of stuff. So actually discussing actual cases and clinical problem solving, I think is a much more effective way of teaching. And so I hope we've managed to increase the confidence of the staff in Weymouth and Portland and in Mid-Dorset and in Jurassic Primary Care Network by doing these MDTs on a monthly basis. One of the challenges, though, is getting people there, because actually, people in primary care aren't generally freed up to do this sort of thing. And of course, if they've got a diabetes, MDT, and they've got respiratory, and they've got frailty, and they've got palliative care, and they've got all these different things going on, it takes them away from their workplace quite a lot. So I can understand that it's quite difficult for them to physically attend. But actually, since COVID, they've all become virtual meetings. And of course, that's much easier for people to attend, to turn up for 10 minutes, present their case, and discuss it, and then leave, and we carry on. And so actually, once again, COVID has been quite good. The other thing that it's helped for me is that I can do it remotely now. So I don't physically have to be in Weymouth or in Bridport in order to do the MDT. And it also means I don't have all the IT challenges they have when I have to go somewhere else to do it and have to find the internet and the Wi-Fi and all of those sorts of things, which are a real challenge. I can get all the pictures, all the information, the x-rays and things onto my screen, and then I can show them to other people, of course, because you show your screen. And so the whole thing is better educationally and actually easier. So that's been very good. The downside of all that is that you don't physically get into the same room as people, and there is a benefit to being in the same room. But even with with Microsoft Teams and the sort of teleconferencing, you do generally, if people turn their cameras on, you do get to see their faces and their responses and things. So actually, it's pretty good. It's pretty good. So that's been the other benefit of COVID to us. It's facilitated us being brave enough to actually say we don't need to physically meet. We can just work remotely, which has been quite good. So those are our MDT meetings. The initial data that I've got, so I've now analysed the data of our referrals from the 3 primary care networks that I deliver the MDTs in, and compared it to the 2 primary care networks where I don't have that, so that's in North Dorset and Purbeck, where we don't have the MDTs. Interestingly, the referrals have gone up in the 3 primary care networks where we do the MDTs. So that fascinates me. That's much more interesting than them going down. And it's very consistent because they haven't gone up from the other 2 networks. I suspect that that's because we're talking about respiratory disease now. We're raising awareness, and people are now much more aware of the things that could be done for people. And I'm hoping I'm hoping it's not a permanent rise. And what I'm hoping is that once they then start feeling more confident, then it'll come down again. But the challenge, therefore, for commissioners of these services is to not use things like referral rates and admissions and things as the end point for integrating. And unfortunately, that is the end point, because, and I understand why it is, because they're wanting to reduce expenditure on referrals and things like that, and this is where they can do it. But I don't think in the short term that's a good measure of success. I'd hope in the medium to long term maybe that would be the case, or at least you'll be able to keep things on a plateau. But in terms of in the short term, I think you've got to be careful what you're measuring in terms of measuring the success of integrated working. It would be lovely to measure patient satisfaction and experience, but that's really difficult to measure on a population level. So outcomes are always a tricky thing, I think, with this sort of thing. It's difficult to do a randomized controlled trial of this sort of thing, even though that's from, as a clinician, I'd love that, but it's actually difficult to do.
That would be a great thing to do, wouldn't it? I think the success measure and outcome measures have always been a really difficult thing to do, and we haven't cracked it yet. Hopefully we will do it at some point. So what do you think the future holds for integration in Dorset?
And so I'm very optimistic that the healthcare in Dorset is going to look quite different in 5 to 10 years' time, and people with chronic diseases are going to feel much better, much better looked after. So that's all encouraging.
Thanks very much to Will McConnell for what Andy and I thought was a really fascinating conversation. We hope you enjoyed it too, and we'll be back soon with another podcast. Thanks for listening.